talking on iliac harvest. Yeah, let's skip the history back. So coming basically to anatomy, you have to understand its vascular supply is basically it's a deep DCIA, deep circumflex iliac artery, and you have a concomitant vein. And the major anatomy that you have to mention, remember is you have got an anterior iliac spine that you can all palpate, you can feel it anteriorly. One, and it's approximately 6 centimeters. You got a posterior iliac crest. That's where your iliohypogastric nerve crosses across. So this is a safe area in which this area where we harvest the anterior iliac crest. So that means you have to leave at least around 2 centimeters posterior to the anterior iliac spine. So you need to maintain the integrity of it, because that's where your the muscle and facial lateral arises that. So you don't want to lose the integrity of the lower limb mass also. So 2 centimeters before it, and posterior limit is posterior iliac crest. So you get a window of around 4 to 5 centimeters. That's approximately that's the amount of bone that you can get, not beyond that. And depth, yes, you can go up to 5 centimeters. So this is the main landmarks that you have to remember: ASIS, anterior iliac spine, iliac crest, and the iliohypogastric nerve which crosses it just behind that. So going to surgical incision, usually it's advised to give around 4 to 5 centimeter incision, but the video actually shows a small incision. Okay, then the placement of incision is very important in iliac. We retract the whole soft tissues medially towards center medially, so that the incision doesn't lie on the crest or it comes laterally. We need to keep it medially. So okay, then after that, this is how it is. So you around 4 to 5 centimeters with a proper traction medially. You place the incision, it goes to the skin, subcutaneous tissue, and you get a scapula fascia. So once you go through the scapula fascia, you have laterally you have what is it? Fascial lateral on the muscle, and medially you have anybody? External and internal oblique muscles. So you get a small area in which you enter it. You can palpate the iliac crest, and you can straight away place an incision on the periosteum there. And only when you incise the periosteum, then you do a subperiosteal dissection. So basically, when you do a subperiosteal dissection, so this is a video I'm going to play it around. So when I'll talk to you one even. So let's let this talk for a minute. Oh, sorry, both are started already. Okay, you can see that the incision is being placed, skin, subcutaneous fascia, and you go to the scapula fascia, and you can palpate the iliac crest and place an incision onto the periosteum directly, and we dissect medially, not laterally, because we don't want the integrity of the facial lata to be affected, because that will affect the limb function as well. So we dissect the medially, and you have to, at all times, it has to be subperiosteal, because we don't want to lose the integrity of the attachments there. So once you reach it there, you can normally you can take a saw or a blade. Preferably saw would be a better option. So 2 centimeter posterior to the anterior iliac spine, and anterior to the, what is the posterior one? Posterior iliac crest. That's the limit that you get. Approximately 4, depending on the age. Pediatric age, probably you might get around 3 or 4 centimeters, or maximum 5 centimeters. You might get a length of it, and depth you can go a maximum up to 5 centimeters. So this is what you get it, and you can see it here. You can see that's you're using a Ferrobue to retract the periosteum. So let's go to the next one. Once it is done, you can use your chisel or your saw, do an osteotomy, one cut, and inferiorly, and all the cuts needs to be done from the medial side, not from the lateral. Lateral integrity needs to be maintained. Once you do an osteotomy, you can just take the bone out of it. You can see the bone is being mobilized. ये आगे पीछे नहीं होता क्या? Look, anyway, don't stop it. You can see that bone is being mobilized there. So basically, the key is the manipulation and osteotomy is all being done subperiosteally, only from the medial side, not from the lateral side. That you need to be remembering at all sort of time. And yeah, the bone is out. Yes. So that's it. So no, it's not necessarily all the time you need to take a corticocancellous. You can you can split the crest and you can just harvest the cancellous bone, or you can take a block bone bone, or you can just make a window, the trapdoor, you can open like a trapdoor and try to take a lot of cancellous bones and you can close back again. The only, it's basically, it's indicated, I'm sure, for a small reconstructions where you need to have less than 5 centimeters of defect, and probably for a malunion and different indications there. But the main thing is anterior iliac spines gives you a less amount of bone. As I said, it can have hardly a depth of 5 centimeters and a width of 4 to 5 centimeters, not beyond that. But on the contrary, the posterior iliac gives a larger amount of bone. Means you can harvest more than 50 cc of cancellous bone, and even larger than 5 centimeters. But to me, very frankly, giving a non-vascularized 5 centimeter bone doesn't make a difference. It doesn't make any use for it. In case if you have a reconstruction to be made more than beyond 5 centimeters, probably a fibula or a vascular graft, any vascular bone would be a better option than what you. Complications is hematoma, infections. Key disturbance happens when you do dissect more laterally. That's what. So try to keep it as medially as possible and retract medially and do subperiosteal dissection. You can prevent it. And all times prevent any herniations. That's the reason I said keep it subperiosteal. So don't herniate, don't violate the periosteum. Chance of hernia is less. And always what we do is we put a drain and we instill long-acting bupivacaine or some local anesthesia before once you do the closure. So that prevents a post-operative pain as well. Just for theoretical posterior iliac, right? This is how it's harvested, not going in detail. So yeah, you get a larger bone chunk, but as I said, yeah, even I have never done a posterior iliac harvest. Basically, there's no. If I have an option to take, if I need a requirement for more than a 5 centimeter long bone, I would rather prefer a fibula or a DCIA rather than going for a posterior iliac. Thank you.
Thank you.